take some questions? No. Just kidding. No questions.
So smart. No questions. Okay, so we were last time talking about the balance of water intake and water losses. And more or less, total water loss is 2.5 liters, and then the gain is supposed to be 2.5 liters. That varies depending on the person, how much water he drinks. And no matter if you need less water than what you drink, whatever you have excess, your kidneys will get rid of it. And then we have factors that regulates water gain, including the thirst mechanism. So when we have thirst, it means that your osmoreceptors in your body has detected increase in osmolarity between 2 to 3%. So that increase in the osmolarity leads to actually your osmoreceptors in the hypothalamus to donate water basically to the extracellular fluid, and that will shrink these osmoreceptors, which will send a signal into these cerebral cortex so that we can start drinking water. And then it will take, when we drink water, it will take 30 to 60 minutes for this osmolarity to go back to normal, and that will prevent overhydration. So here is the image, or the cycle showing you how we control water based, on the intake of water balance based on the intake of water when your osmolarity increases. So here is the stimulus. So let's say that you drink a sugary drink, or you ingest something that is very salty. So that increases your osmolarity in your blood. So it go a little bit above 270 millismoles per kilogram. And then this plasma, which is basically high in concentration solids, as you can see here, reaches the osmoreceptors that are found here in the hypothalamus. And then your osmoreceptors shrink because they, with osmosis, they donate water to this extracellular fluid, which is hypertonic. You can tell because you have excess of solutes. And then you will send a signal into your cerebral cortex that will make you to go and drink water, and that will return the blood volume, reducing the osmolarity. So your solutes that were highly concentrated here become diluted, so that leads to isotonic extracellular fluid, and that prevents from you to drink more water. Now, when you have a decrease in blood volume, like for instance, if someone has a hemorrhage, in this case, your blood volume goes down, and then remember that we have here these receptors, the smooth muscle cells within the juxtaglomerular apparatus that can detect less stretch, and that stimulates your juxtaglomerular cells to release renin. And then renin will convert angiotensin into angiotensin 1. Angiotensin 1 goes into your lungs. It will be converted into angiotensin 2. That will be a powerful vasoconstrictor. And then you will have aldosterone released from your adrenal gland, which is going to lead for reuptake of sodium and water. And then we not only have these receptors here for blood volume in the kidneys, in the glomerulus, but also we have it in the carotid arteries and also in your aorta, in the aortic arch. So one of the responses, if this is not controlled, is fainting. If your blood volume goes down and then you don't receive as much blood into your brain. But something that happens along the way, it is a stimulus of the third center in the hypothalamus. So the person will drink water, and then the water is reabsorbed by the kidneys, that returns the blood volume. So that's an example of feedback of how to maintain homeostasis. So if someone doesn't ingest enough water, or if the person loses blood volume, the person will have dehydration. So in dehydration, someone can have increased osmolarity, and in this case, this may be treated with pure water if it's consumed in moderate amounts, and if the person is ingesting food, within this food maybe some salts, that will prevent the dilution of the extracellular fluid. But let's say that someone will receive an IV line with hypotonic solution. So in that case, the osmolarity will be decreased. And although you increase the blood volume, that it is not good, because that is going to shift water back into the extracellular fluid. But if large amounts of water will be consumed too quickly, the extracellular fluid can be overly dilute, and that will result in cell swelling and edema. So something that it is useful then to hydrate a person, it is to use, of course, these solutions with electrolytes that can compensate for a lack of electrolytes in the extracellular fluid. And that at the same time, when you have sodium, for instance, in these solutions, will help for the reabsorption of volume within the kidneys. And then, if you remember, we have receptors, transporters, co-transporters for sodium and glucose in the kidneys, and also in our intestines. So that will help when you have electrolytes combined with glucose to reabsorb much easier electrolytes, and then this glucose that at the same time helps to produce more ATP, which helps for having balance, because we have the functioning of ATP, of this sodium-potassium pump with ATP, along with other pumps. Overhydration or hypotonic hydration. So this is when you have increased volume and decreased osmolarity. So this results when your extracellular volume increases and the osmotic pressure falls. This hardly happens, but it can happen, and then your cells will swell as water enters the cells by osmosis. Sometimes what can happen is that your ADH levels drop, antidiuretic hormone. Remember, this one is released by the pituitary gland, but it's produced by the hypothalamus. But let's say that someone has damage to the kidneys, and the kidney function is impaired, or if ADH is abnormally secreted, or if someone take excess of water, well, this mechanism can fail. And then hypotonic hydration always results in electrolyte imbalances. So this because it dilutes the extracellular fluid. So something that it can happen as a result of this, because you are over diluting your plasma, you can end up with hyponatremia, or low concentration of sodium. But it's not necessarily that you don't have sodium. It's just like plainly you have normal levels, but you have more water. And in this case, you have cellular swelling, especially in the brain, and that can lead to death. And then it starts with cerebral edema. So that can lead to coma first, and death, and then the person can have seizure as well. So then hyponatremia is not good. Treatment includes give hypotonic fluids draw water back out of the cells. Another case of water imbalance will be what is called isosmotic fluid imbalance. In isosmotic fluid imbalance, your levels of ions will remain the same. So sodium supposedly has to be at 145 milliequivalents in the blood, and then chloride 117 milliequivalents. So nothing changes. But what can be the causes? Well, blood loss. When someone has blood loss, you deplete volume because you're losing plasma, and together with plasma goes all of these ions. And this blood loss can be hypovolemia that can lead to shock, organ failure, and death, depending on how much blood loss you have in the amount of time, and if you restore or not this volume. And then one example of treatment for hypovolemia will be give isotonic fluids. You cannot give hypertonic fluids or hypotonic, because hypotonic, you don't have edema, hypertonic, you don't want to dehydrate your cells. And then what is the opposite fluid imbalance? Hypervolemia, that is isosmotic. Well, this can happen when you increase your extracellular fluid, and it can be because someone received an extra amount of volume through an IV line. That's like the most common cause, which rarely happens, thankfully. But in this case, you can have basically swelling, especially if your kidneys are not functioning properly. But if not, what will happen is that you will release H1 peptide because you have this tension of your right atrium as you receive more blood volume into your right atrium, and that will lead to loose water and sodium, independently that you have normal levels of sodium that ultimately can lead to hyponatremia. And there is no more sad thing than to see someone who has renal failure to receive even what is considered normal levels of isotonic fluid when whoever prescribes it knows that the person has renal failure. Because it's like what happens with the elderly. In the elderly, the mechanisms to detoxify drugs is reduced, so they cannot receive the normal levels of drug as a normal adult. So they have to adjust the dose. So in the case of someone who has renal failure, it cannot receive normal levels of volume as someone who doesn't have, which can happen. I have seen it. And then I have seen also what happened to these persons. So that's another case of hypervolemia. And then something that happens with this hypervolemia that it's common as well, it is that you can have low colloid osmotic pressure, or removal of the lymphatic vessels, or inflammatory mediators that are released because someone might have an allergic response or have high hydrostatic pressure. And that is seen with hypertension. And then you will have decreased venous return blood into the heart and excess of sodium retention. So how do you manage that? By using compression garments, removing excess of fluid with medications like in the case of diuretics, you can use that. And of course, again, that is supposed to be when the person doesn't have any kidney problems. And then treat the underlying cause if it's one of these causes, like when you have excess of inflammatory mediator molecules. Now, for balance of specific electrolytes, so we have sodium ions, which are the most common or the highest ion that we have in the extracellular fluid. And we have between 135 and 145 milliequivalents per liter. It's tightly controlled. And we have, again, the sodium-potassium pump that helps to maintain that balance between the intracellular compartment and the extracellular compartment. And why it's concentrated highly outside the cells? Well, because although we have leaky channels in the plasma membrane for both potassium and sodium, we have less sodium channels than potassium channels, which keeps sodium outside the cells. And that creates a steep gradient that helps for excitable cells to work, because if you have more positive charges outside the cells and you have negative charges inside the cells, which is a steep gradient, that attracts the sodiums to come into the cells and then start an action potential through depolarization. So this is what happens then. So if you take an electrode inserted in one of these excitable cells, during resting membrane potential, you have a voltage here shown in this y-axis of minus 70 millivolts. So your cells are negatively charged when you don't have functioning or a particular action that you do. But then you open your sodium channels gradually, and then you depolarize the cells from minus 7 to minus 55, and then you reach a threshold, and that opens all your sodium channels, sodium influx into the cells, and then you reach plus 30. So that's the part of depolarization created by this influx of sodium. So sodium is an electrolyte, can carry a positive charge into the cells, make them less negative. Now, how we maintain homeostasis of the extracellular concentration of sodium? So that will be by a negative feedback loop. So if you have hyponatremia or less than 135 milliequivalents per liter of sodium, that will trigger your receptors in your macula densa, in your nephrons, to detect this change, and that will activate your renin-angiotensin-aldosterone system. And then with this, you will lead to the release of aldosterone, which is going to help for the absorption of sodium, and that will normalize your sodium levels. Remember, aldosterone is also known as salt-retaining hormone. So, why does the amount of water in the body affect the sodium ion concentration? So here it tells you about this example with 3 beakers. So in beaker A, which is this one on the left, you have a 10% sodium chloride solution. And then when you have same amount of sodium on beaker B than in beaker A, but your volume is less, that increases your concentration of sodium. And this is sodium chloride. It's not only sodium, but it's sodium chloride. But then when you have the same concentration of sodium that you have in here, but with more water, that leads to less concentration of sodium. And I'm sorry, it will be amount. So let's say you have here 10 milliliters of water in this beaker. And that has a 10% concentration of sodium chloride. So if you have 10 milliliters of water in this beaker A, how many grams of sodium chloride you have to be 10%? So 10 milliliters on beaker A, and you have a 10% concentration of sodium chloride. So how many grams of water are you supposed to have there? 1 gram. So that makes it 10%. And then in beaker B, you have 1 gram, same as this, but instead of having 10 milliliters of water, you have 5. That makes it 20%. And then in this beaker, instead of having, you have 1 gram of sodium chloride, but instead of having 10 milliliters or 5 milliliters of water, you have 20 milliliters. That makes it 5%. So this is what happens in our body. Sometimes you can have the same amount of chloride, sodium chloride, but you can increase or decrease the concentration, the amount of water based on your intake. Let's suppose that you don't have taken food in certain amount of hours, but you only drink water, and that water is pure water. So that can have a dilution effect if you drink a lot of water, or a concentration effect if you don't drink water. So that's how we affect the sodium concentration, depending on how much water do you drink or not. And I have told you this before in an osmolarity example. It's like if you are cooking a beef stew, and then you have added the right ingredients, but then you let it sit for longer than usual, and then you taste the beef stew and taste too salty. Would you throw it away and start a new beef stew? Or what would you do to decrease the saltiness? You pour more water. But then you over added water, and then you taste it. Now it's going to taste what? Less salty. So that's what happened to us in our blood. We can be sometimes with the right concentration of salt, less or more, depending on how much water do you drink. Now for potassium ions. Potassium are just like as sodium. They have a positive charge, they are cations, but they are concentrated more inside the cells than outside the cells. And why? Because we have more potassium channels, leaky channels, than sodium channels. And that amount intracellularly is 139 milliequivalents. And then the extracellular compartment has very low sodium, 3.9 to 4.5 milliequivalents per liter. And just as the sodium concentration, potassium concentration is maintained in between the compartments by the sodium-potassium pump. And then when you open your potassium channels after you reach the peak in the action potential of excitable cells, sodium exits the cells. That leads to repolarization and sometimes hyperpolarization in your excitable cells, which are the neurons and the muscle cells. And same for calcium and phosphate ions. You have calcium ions that are required for contraction of any muscle, like cardiac, the smooth, and skeletal. And when it comes to the action potential in the heart, if you remember, you have to have more calcium inside to maintain a strong contraction for a longer period of time, because the heart has the most important function of any muscle type that we have, which is pumping the blood to deliver it into the body. So they have to contract stronger and for more period of time. So that's why we have this plateau that it is necessary for that to happen. Another function of calcium in our body is helping to maintain intracellular signaling. There are certain enzymes that requires calcium, or cascade of signals that requires calcium for that to take place. And also helps for the release of neurotransmitters. So when you have calcium entering into your axon terminals, you can release these neurotransmitters into the synaptic cleft. And as well, it participates in blood clotting. No calcium available, you don't have formation of blood clots. So something that happens when your concentration of calcium ion increases, your neuron become less permeable to sodium. And about 99% of the calcium, it is stored together with phosphate in the bones as hydroxyapatite salts. So that maintains a strong bones. But also is located in dentin and then in enamel. Bone is the third strongest tissue in our body. The first one is enamel, the second is dentin in our teeth. So when someone has hypocalcemia, you expect that not only their bones become weak or osteoporotic, but also the person starts losing their teeth. And then phosphate ions are part of these ions that are regulated together with calcium, is found in hydroxyapatite crystals. It's a hard word to say. And is regulated in tandem by the same hormones. So what hormones controls calcium? Calcitonin and parathormone. Calcitonin is released by the C cells of the thyroid gland whenever you have hypercalcemia, because you ingest good amounts of calcium, your bones become stronger. So the calcitonin helps for the depositing of this calcium in your bones. And then what happens if you have hypocalcemia, if you don't ingest enough calcium? In this case, your parathyroid glands, which are located posterior to the thyroid gland, they release parathormone or PTH, which makes your osteoclasts in your bones to start chewing up the bone, and the bone becomes weak. So that's how you regulate your calcium. And then the same hormones regulates these phosphate ions. And phosphate, remember, is not only part of the phospholipids, but it's also part of the ATP, adenosine triphosphate. So how many phosphates we have in ATP? Adenosine triphosphate, 3. So this is the normal levels of calcium in our blood, between 8.7 to 10.4 milligrams per deciliter. And is again one of these ions that is tightly regulated as well. And a vitamin that is necessary for the absorption of calcium is vitamin D, and then calcium will be absorbed in the small intestine. And then more ions will be reabsorbed from the filtrate in the distal tubules in the collecting system when you have vitamin D. Phosphate ions is not as tightly regulated as calcium, but generally the body maintains a slightly lower concentration than calcium. And sometimes in some events you can have exchange of calcium for phosphate as you reabsorb calcium. So again, here are the participants for regulating calcium. We have PTH. So it's released when you have a decrease in calcium. And then this PTH decreases the absorption of phosphate ions. So that's what I told you before. You can switch. So you reabsorb calcium instead of phosphate. And then this one activates vitamin D3. Vitamin D3, remember, it is normally produced by our body. So we have a precursor of vitamin D in our skin. You expose yourself to the sun, that molecule starts being activated, goes to the liver and the kidneys to be hydroxylated twice, and then you have calcitriol, which is vitamin D3, to be able to reabsorb calcium, and also triggers the reabsorption of phosphate ions so that they don't fall that much. So what is hypercalcemia? Having 10.5 and above levels of calcium. Why it can happen? Well, someone may have hyperthyroidism in which they release excess of PTH, and then that also happens in certain cancers that releases PTH, excess of vitamin D, certain bone disorders, or renal failure. Renal failure can lead you to hyper of everything because you don't get rid of the ions. So you can have hypercalcemia, hypernatremia, hyperphosphatemia, etc. And then what can happen if someone has hypercalcemia? It will have mental sluggishness, reduced reflex activity, weak muscle activity, shortening the plateau phase of the action potential in the cardiac muscle, and then ectopic calcifications in the muscle or even in the kidneys. So you can have kidney stones, decreased appetite, and constipation. Hypocalcemia is having levels of calcium lower than 8.7 milligrams per deciliter. That can be because someone has decrease in the release of PTH, or maybe the PTH is not functioning as it's supposed to. And this occurs with renal failure and vitamin D deficiency as well. And your neurons become hyperexcitable. So something that happens in our muscles when you have severe hypocalcemia is that you have a spontaneous generation of action potentials, which can lead to contractions of the muscles, especially in the hands. So this is called carpal pedal spasm. And then that sometimes also can lead to tetanic spasm of the respiratory muscles. When your levels are super low, lesser than 4 milligrams per deciliter. So here we have carpal pedal spasm due to hypocalcemia. And sometimes you can feel some tingling along the nerves due to this hypocalcemia. Chloride. Chloride is a negative charge ion. It's an anion. Is having higher concentration in the extracellular fluid because just as sodium attracts chloride because of a positive charge. So it makes sense then that both of them are highly concentrated outside the cells. And then this chloride is important for producing hydrochloric acid in the stomach. And it is involved in secretion of newly formed bicarbonate ions from erythrocytes coupled with the reabsorption of sodium in the kidneys. So if you reabsorb sodium, you reabsorb chloride. Magnesium, it has, just like as calcium has a 2+ sign in it. It's a divalent ion. It is a cofactor of many enzymes. So remember, some enzymes, they don't work well if they don't have particular ions, like magnesium, it can be one. Magnesium salts are important in the bone tissue. It can block entry of calcium into the cells. So kidneys excrete much of what is ingested. And if you over-ingest magnesium, you can have diarrhea. So it's a mild laxative. Any questions about control of ions? So we talk about balance of water, balance of ions. Now let's talk about acid-base balance. And you saw a little bit of this at the introduction of this chapter. So we have a subdivision of molecules, certain molecules, into acid and bases. Acids will donate hydrogen ions, bases absorb hydrogen ions. And these acid and bases are part of the metabolic processes that we have in our body. So we have also the production of these acid and bases as part of the metabolism. So we have metabolic acids that includes carbon dioxide that it is produced during the Krebs cycle. And this carbon dioxide, when it is condensed with water, would form H2CO3, which is carbonic acid. The same enzyme that you have heard about before in AMP1 and now in all the systems that we have talked about does this conversion of water and CO2 into carbonic acid. And this carbonic acid, by the same enzyme, can be broken down into hydrogen ions and into bicarbonate ions to maintain a specific concentration of hydrogen ions, which is necessary for the function of different enzymes. And then carbon dioxide is considered a volatile acid because it can change states from liquid form into a gas in the lungs. And then this can be eliminated from the lungs during exhalation, and you can return to normal levels of CO2. Now, in order to control the levels of hydrogen ions in our body, we have buffers, which are molecules that has a base, a part, and an acid part, so it's a conjugate molecule that can serve as an acid donating hydrogen ions when needed and absorb hydrogen ions when needed. So when a strong acid is added into a solution, the weak base of the buffer system will bind this excess of hydrogen ions, and vice versa with the strong base. So the purpose of having these buffers is just to prevent huge changes in the concentration of hydrogen ions. And then we have a specific amount of bicarbonate, which is an alkaline reserve that has buffering capacity in the body fluids. So here's the chemical reaction then of this carbonic acid bicarbonate ion system. So CO2 combines with water, so H2 from here, and then another oxygen you added here will be H2CO3 minus, that will be carbonic acid. And then this is a reaction that it can go in both directions. Carbonic acid can be converted into water and CO2. This happens in the lungs. It goes more in that direction when you have acidosis and you hyperventilate. Now, to get rid of this CO2. So you increase your respiratory rate. And then this carbonic acid can be converted into bicarbonate ions and into hydrogen ions. When you need to have hydrogen ions in your body during alkalosis. And then same deal, you have reaction going in both directions, so you can combine hydrogen ions with bicarbonate to form carbonic acid. So some of these sodium ions that we have in the bloodstream can be combined with bicarbonate to form sodium bicarbonate, or can be dissociated from sodium bicarbonate to just form bicarbonate ions. So here is an example of how the chemical buffer system works. So here you have a solution with neutral pH, and then if you add the base, this neutral pH will go toward the basic spectrum, which will be up to 14, depending on how much base you add. But if into this solution that you have added the base, you add a buffer, you return closer to neutral, depending on how much buffer you add. But this buffer then will absorb, in this case will be bicarbonate, will absorb the excess of base. And then it will be the opposite in this side. So if you have acid added into this neutral pH solution, your pH will drop your concentration of hydrogen ions increases. And then if you add a buffer, that buffer that has this bicarbonate will pick up the excess of hydrogen ions, returning this solution to neutral pH. Any questions? So it's like a good friend, right? When you lose money, he lends you money. When you have, and then when you have money, you return it to that person. So that's what you do. And then here are the definitions that we saw before. It makes sense to review it. So we can have strong acids, strong bases, and weak bases, and weak acids. So weak acids and weak bases, they can donate or accept excess of hydrogen ions, but they do it gradually. While in strong acids or strong bases, you will have a complete dissociation of them, so releases most of the hydrogen ions or access more of these hydrogen ions really quick, so that impact the pH in the solution much efficient in a way than the weak bases or weak acids. And then we have not only this carbonic acid bicarbonate buffer system in our body, but we also have phosphate buffer system. So the phosphate buffer system, it's a weak acid, like this dihydrogen phosphate, and its conjugate base, which is this hydrogen phosphate. So the difference is that you have here 2 hydrogen ions, and here you only have 1 hydrogen ion. This balances excess of hydroxide and hydrogen ions, respectively. So this one balance excess of hydroxide ions, or OH, while this one excess of hydrogen ions. So this one is found in the cytosol. So this is an intracellular buffer, the phosphate buffer system. And then also is found within the filtrate, within the kidney tubules. So carbonic acid system and bicarbonate ion system, it is fast in comparison to the next system, which is the protein buffer system. Proteins, since they have an amino group and a carboxyl group, they can accept or donate hydrogen ions, which makes them a buffer. But that's something that our cells don't like, because you will be using precious proteins to buffer, but it can help. So the carboxyl group is COOH minus, and this one can ionize to their weak base to bind hydrogen ions. And 60 to 70% of the total body buffering capacity, it is found in the cytosol. And then hemoglobin will be one of these buffer systems. So it accepts hydrogen ions, and then it can work together with this carbonic acid system to control pH, as we saw it before in the respiratory system. We saw how this exchange happens. Now, the respiratory system and the urinary system helps to control the pH. So for instance, when we have excess of CO2, which drops your pH, which increases your hydrogen ions, your respiratory system responds by increasing the breathing time. So you have tachypnea, so you get rid of as much of CO2 as possible. And this happens as well when we become physically active. When you become physically active, you normally produce more acids, like lactic acid, pyruvic acid. And those acids, together with CO2, we have to be eliminated. So you start breathing more to match the production. And then the respiratory system also influences the production of bicarbonate ions. Now, your urinary system can excrete fixed acids like lactic acid, ketones, phosphoric acid, uric acid, ammonium ions, and bicarbonate ions. And it can produce bicarbonate as well when it's needed. So about 25% of the hydrogen ions are actually eliminated by the kidneys. So when you have excess of hydrogen ions in acidosis, your urine becomes more acidic. And then you start producing bicarbonate and you start absorbing more bicarbonate. So you eliminate less bicarbonate and then you eliminate hydrogen ions when you have acidosis. And although the urinary system is slow in responding, it is very effective in controlling the pH. So nearly 100% of the bicarbonate ions are reabsorbed in the tubules of the kidneys when you need to have this buffer, when you have acidosis. And then, of course, you expect that when someone has renal failure, this buffer system of the kidney fails. So they don't have this capacity of buffering. And then hydrogen ion secretion and bicarbonate ion happens in the PCT, proximal convoluted tubule. And then something that happens during this process is you have a molecule that's called glutamine that enters the PCT and then undergoes a reaction that yields two ammonia molecules and two bicarbonate ions. So now the ammonia, what it's going to do is going to combine with the hydrogen ions and it's going to produce ammonium. And then these ammoniums will secrete into the filtrate. So the person will have, in this case, a smell of ammonia in their kidneys. And then the bicarbonate ions, once they are produced or reabsorbed, will go from the tubular fluid into interstitial fluid, and then together with sodium will be reabsorbed into the bloodstream so that you can reduce acidosis. So here we have glutamine in this area, in the PCT. It will come in, and then this glutamine will be converted into ammonium that will combine with reabsorbed hydrogen ions, so you will have ammonia, and that will be excreted into your lumen of the tubular fluid. And then here at the basal side, this glutamine that has been dissociated into ammonium and into bicarbonate, the bicarbonate will be going in the basal side of the proximal convoluted tubule cells into the interstitial fluid and then enter into the bloodstream, helping to buffer the excess of hydrogen ions in your bloodstream. And at the same time, you eliminate hydrogen ions in here. And then if you still have excess of hydrogen ions, your DCT and even your convoluted tubules can get rid of these hydrogen ions. So you will have excess of CO2 in your bloodstream that will diffuse into the interstitial fluid and then into your cells of the distal convoluted tubule, and then CO2 with water will form carbonic acid by the carbonic anhydrase enzyme. And then carbonic acid with that same enzyme can be broken down into bicarbonate ions and then into hydrogen ions. Hydrogen ions are excreted because you don't need them, and then bicarbonate will come here to react again with whatever excess of hydrogen ions you have to start over that cycle. So that's the mechanism of secreting hydrogen ions in both distal tubule and the collecting system. So how do you change the level of carbon dioxide in the blood to help to decrease or increase the levels of hydrogen ions? Well, when you have your pH of 7.4 in your plasma, you have normal levels of hydrogen ions from the metabolic acid that you produce. And then you have some hydrogen ions from this carbonic acid. But if someone has metabolic acidosis, like if they have excess of hydrogen ions, either from metabolic acids or from carbonic acid, that will trigger the mechanism of increasing your production of bicarbonate or the actual increasing of your respiratory rate so you can get as much as possible of CO2. And then your kidneys also will respond by eliminating excess of hydrogen ions. So ultimately, you will have hyperventilation, you get rid of CO2, and those levels of acids, the hydrogen ions, will become lower, so bringing back your pH to 7.35 to 7.45, which is the normal pH. So as carbon dioxide molecules are exhaled, your number of hydrogen ions will decrease. So that's acidosis. Now for alkalosis, the opposite, where you have low levels of hydrogen. So this will lead to alkalemia, which is having a pH of 7.45 and above. And since you need to have these hydrogen ions, you will have a lower respiratory rate. And then that's supposed to increase your levels of hydrogen ions because you will retain CO2. And when you have CO2 available, you can combine it with water. You form carbonic acid, and then you can break down this carbonic acid into bicarbonate and then into hydrogen ions, and you eliminate the excess of bicarbonate and you retain the hydrogen ions. So that's how you control it. And then what are the signs and symptoms of alkalosis? Excitability of the neurons increasing. You have numbness, tingling, muscle twitches, and tetanic contractions. And that eventually can lead to seizures and death because your muscles of respiration do not relax, and you need that to breathe properly, relaxation of your respiratory muscles. Now, in alkalosis, you can have two types. You can have respiratory or metabolic. Respiratory happens when you have damage to your muscle cells of respiration, or when you have maybe a damage to your respiratory centers in the pons and the medulla oblongata. That leads to hyperventilation, and that can lead to decrease of CO2. As well, if someone moves to an area where you have high altitude, where you have low PO2, your body will respond by breathing more. That can lead to hyperventilation. Well, that's hyperventilation that can lead to decrease in CO2. Now, most of the times, this is temporary. It happens because someone received bad news, the person cannot control its emotions, overbreathes, and that makes the person to eventually faint. But one way to help it is to ask the person to calm down, and then if you have available a brown bag or a bag, ask the person to breathe together with their mouth and nose inside the bag, and that person will breathe in its own CO2. That increases the hydrogen levels. Metabolic alkalosis happens from loss of hydrogen ions or excess of bicarbonate ions. So an example is excess of vomiting. When you vomit excessively, you're losing hydrochloric acid. So that leads to metabolic alkalosis. As well, some diuretics let you to lose some of these hydrogen ions, and someone may have excess of aldosterone. So that leads to increased sodium reabsorption with concurrent secretion. As you reabsorb sodium, you excrete hydrogen ions. So that can lead to metabolic alkalosis. Or perhaps someone overingests bicarbonate salts or oral antacids, like Tums. Some people think that Tums is a candy. No, it's not a candy. So that can lead to alkalosis, metabolic alkalosis. So what is the response? Well, you hypoventilate to retain CO2 and increase the hydrogen ions, and your kidneys will reabsorb more hydrogen ions and secrete bicarbonate. ABGs, arterial blood gases. So in order to study the levels of oxygen and CO2, which is part of the diagnosis of alkalosis or acidosis, you have to withdraw the blood from an artery. It can be radial brachial artery, it can be even from the femoral artery. And then you not only measure the levels of oxygen and CO2, which is PCO2 or PO2, but also you can measure the levels of hydrogen, the pH. And depending on what you have, either alkalosis or acidosis, you can have a compensation, full compensation, or partial compensation, or not at all. So uncompensated means that you don't have a response from the body, and you don't expect in a kind of a reasonable period of time from that to happen. And then partially compensated, that means that some of these pH has been going back to normal in response to the organs, and hopefully you have fully compensated acidosis or alkalosis in cases where your function of your organs is not affected. So what are the things that you can expect in each situation? So in respiratory acidosis, you will have hypercapnia or elevated levels of CO2, partial pressure of CO2. And you can have either a normal blood pH or a pH lower than 7.35. And if the bicarbonate ion levels is elevated, that means that your kidneys have starting to form them. So that's a partial compensation. Fully compensation will be when you have also the kicking out of these systems like the respiratory system, breathing more to get rid of excess of hydrogen ions. In metabolic acidosis, the general rule of thumb is that you'll have decreased pH and lower bicarbonate ions. So when you have low bicarbonate and then you have high CO2, that means that you have metabolic acidosis. So this CO2 is lower than the respiratory acidosis because your lungs start compensating. So you start breathing more to get rid of CO2. In respiratory alkalosis, you have elevated blood pH, so greater than 7.45, and your CO2 will be lower, hypocapnia, your partial pressure of CO2. And then your bicarbonate levels will be low. in respiratory alkalosis. This is partial compensation from the kidneys, meaning that you are getting rid of excess of base. You're starting eliminating this excess of base of bicarbonate. And then metabolic alkalosis. In this case, you have, of course, a pH greater than 7.45, and you have high level of bicarbonate. If you have respiratory compensation, your CO2 will be elevated. So, the compensation of metabolic alkalosis by your respiratory system will be decrease the breathing so that you will have retention of CO2. And that's a summary of all of these disorders. What can be the causes of respiratory acidosis? Well, you may have a blockage in your respiratory tract due to an obstruction, internal, external, due to a tumor or a foreign object that you have aspirated, or you have decreased gas exchange in your alveoli. Maybe you have emphysema. You may have damage to your brainstem in an accident, a whiplash. Respiratory alkalosis. You have a hyperventilation, a tumor in your brain that stimulates more breathing than usual. Or again, when you go to high altitude places. Metabolic acidosis, you have prolonged diarrhea, excessive production of metabolic acids. Maybe someone has cancer or something that increases the metabolic rate. Renal failure, ingestion of acids, drugs or toxins. There is such thing as someone over-ingesting aspirin that leads to metabolic acidosis. Metabolic alkalosis, excessive vomiting, ingestion of diuretics, and excess of aldosterone. So that is all for this chapter. Do you have any questions?